obviously, if you're treating PAD and definitely CLI patients, this is going to be your typical clinic, either on a daily or weekly basis. And you're going to be treating some type of patients that look like this pretty routinely. And everybody always wants to get some level of a 3-vessel recanalization, which is not always possible. But to do that, you have to have some understanding of basic tibial artery disease. When you're dealing with below-knee disease, you have to realize that you have really long diffuse stenoses or long chronic total occlusions. They're typically heavily calcified about 75% of the time, and that's even higher in diabetics and patients with CKD. And we know there's some early histologic work where they're finding cells of cartilage and bone in these CTOs below the knee. And so you can imagine that crossing these CTOs can be difficult and sometimes not possible. And, you know, compared to above knee disease, SFA and popliteal and so forth, you don't have as many bailout options when you end up with complications such as long segment dissections and ruptures. Obviously, we've got a lot of these long drug-eluting stent trials that are taking place now. And what will happen is that adds something to the landscape. If you've never seen a CTO, well, this is what it looks like under a microscope. You can see that all these black arrows are pointing to really tiny, tiny micro channels. And so this gives you an appreciation for when people talk about guide wire escalation, 014, 018, 035, etc. And what they're talking about is trying to get these guide wires into these. Obviously, the more heavily calcified the artery, the more disrupted and the lack of microchannels you'll have, as Kumar alluded to. When you think of CTOs and below-knee disease, you want to really study your angiograms. You want to look at the cap morphology. Obviously, with CTOs, you've got a proximal and distal cap. And so when you look at these, although you don't have to, you know, necessarily know the names in these guides, this is a nice paper written by Mustafa and Fadi et al., which really looked at about 3,000 patients, and they talked about different cap morphologies. So if you look at type 1 there, obviously that cap is favorable from an approach from above because your guide wire or catheter system are more likely to engage kind of the apex of that cap, and you'll at least start out intraluminal. Where you end up obviously depends on your recanalization. If you look at types 3 and 4, the idea is that your catheter or guide wire are more likely to hit that cone or the apex there and then slide off into a subintimal space. And so then you're going to have to do something to re-enter into the true lumen at some point, whether that's different guide wires, catheters, re-entry devices, and so forth, depending on where it is. So the idea is that just think about cap morphology. And here's an example of that. This is a CLI patient. You can see has a popliteal artery occlusion at the level of the knee joint. You can see that that proximal cap is pretty complex with a lot of big blood vessels coming off of it. Compared to the distal cap, which is really the anterior tibial artery, you can see that's a more favorable cap for a retrograde approach. So in this case, although I have antegrade access with my sheath and catheter system as distal as possible to obtain this angiogram, I decided to on a retrograde approach. And you can see that with a classic technique, it literally took 5 seconds. So it shows you that analyzing your angiogram, looking at the proximal and distal caps, very important and can sometimes make things easier in the long run. Another basic concept you want to realize is that when you're talking about CTOs, there's the concept of the hibernating lumen and the non-hibernating lumen. And obviously we talked about proximal and distal caps. When you have nothing in between, that is a hibernating lumen. That channel is patent. It may be angiographically occult, you don't see it, but it's patent and it's open. And obviously that type of recanalization, once you get through that cap, is much easier than say a CTO that has no hibernating lumen. In those cases, you can see that you're going to be fighting your way through that entire occlusion. And I'll show you why this is pertinent later. And here's an example of that. So here's a patient, again, CLI, has a large wound on the bottom of his foot. You can see the posterior tibial artery is out. We don't know the status of the common plantar artery, the medial lateral plantar arteries, and so forth. Once the recanalization was complete, you can see that angiography shows really robust filling of a lot of vessels there, and you have a nice angiographic wound blush. So this is a classic example of angiographically occult vessels that are really patent in between the CTO caps, and shows you the concept of a hibernating vessel. Here's another case. CLI patient has a robust perineal artery with nice anterior and posterior communicating branches. You see there's a stump of a dorsalis pedis. So we don't know, do we have to recanalize the AT plus the DP plus the pedal loop? But once the recanalization was done, where we were through, our catheter tip is at the red arrow, you can see there's robust filling of a lot of blood vessels in the foot. These were all hibernating. They were open. They were angiographically occult. The final concept before we get into our cases is you really want to think about direct versus indirect revascularization. So when I look at angiograms, especially below the knee or below the ankle, in the case of pedal loop reconstructions and so forth, I'm looking to see that will I be able to achieve a direct revascularization, in other words, opening up the blood vessels that supply the problem or the abnormality directly. It's the main blood vessel to that target issue. Or do I have to open up blood vessels that supply collaterals, which then perfuse or supply the area of interest? And here's a quick example of that. This is an example of a direct revascularization. You can see patient has profound ischemia. You can see that the dorsalis pedis is out, the AT was out. We did a recanalization. In this case, I opened up the target vessel for the abnormality at hand. And after reconstruction, you can see that there's robust filling and then resolution. So that's direct revascularization, or angiosome directed is the other term you want to think about. When you're thinking about indirect, you can see here's another patient who had a TMA, has wound dehiscence, gangrene, and is obviously at risk for a major amputation at this point. I was unable to open up the anterior tibial or posterior tibial arteries, as this was a diabetic CKD patient. Didn't matter what I did. So what I ended up doing was opening up the perineal artery, TP trunk and perineal artery. And you can see that after that was revascularized, we have robust filling of really the anterior and posterior circulation of the foot. And in this case, we were able to achieve healing, although it took a longer time than a direct revascularization, with this indirect revascularization. So we open up a vessel, collaterals are supplying the area of the abnormality.